Thank you. It's such a great pleasure to be here. I was a very lonely low-carb GP for so many years, and they said he's a maverick and he's a bit odd and all the rest of it. But to come here and find I've got an enormous tribe and everybody's saying like, well done, it means it's quite emotional. It's amazing. Thank you so much, so much. Thank you. So, I was trying to think what you might be interested in. So we're going to talk a bit about the glycemic index and how I used it in primary care to sort of bring about a low-carb practice. So I've looked after the same population of people for 30 years now. We've got 9,000 patients and there are five partners. For the first 25 years, I became very disappointed really in what I was able to do, very disappointed, particularly around diabetes and obesity. And you're going to see the story, and obviously there, I won the NHS Innovator of the Year for the UK for the work on low carb. So something amazing happened in between me getting ready to retire really, and I used to avoid people with diabetes and obesity. In fact, I gave it all to a junior partner, as you do, and now I've taken it back again because they're now my favourite, absolutely favourite patients. So something pretty great has happened, and it involves two women, two clever women, and a single interesting fact. I got an email saying I ought to tell you about disclosures. I wasn't sure what that was. One of the problems we all have is getting funding. Because Big Pharma don't really like us much. In fact, and then, you know, should I go to the egg people or who shall I go to? So what we've actually done, our practice just got one little grant of £7,500 after about year one, and we funded the whole of the rest ourselves. What I would say is that it has cost us money, but has been such fun that I don't care. It's been such fun. So that's the disclosures. We've not had very much from anybody. What's next? Yeah, so the glycemic index, you're such a sophisticated crowd. I think you know about the glycemic index already. But if there is maybe just the odd person that doesn't, it gives an idea, if you're looking at carby foods, how that would affect your blood glucose over the following couple of hours after you take it in. So the first is a single interesting fact. I read in the British Medical Journal, right at the start of my journey, the fact that the glycemic index of healthy wholemeal brown bread was worse than table sugar. I couldn't believe that. I thought it's got to be wrong. And I was all ready to write to the editor, you know, like the cross old guy that's always complaining, and say, you are wrong, you are wrong. And I looked it up and it is not wrong. The glycemic index of healthy wholemeal brown bread is significantly higher than table sugar. And therein lies a clue, really, to what we should be doing with carbohydrates. We next come to a clever woman. A clever woman. So I was worried about one of my patients because she wasn't taking her drugs. That's really naughty, isn't it? Not taking your drugs. And she was ruining my practice statistics because we were sort of paid horribly to do with take your drugs, and she wasn't. I was worried about, I wrote to her and said, please come and see me. We need to have a chat about your compliance. And she wasn't keen in coming, but I cornered her eventually, and she came. And what really was amazing, I called the lady in, and when the lady came in from the consulting room, I didn't recognize her. I really didn't recognize this lady. I thought I'd called in the wrong patient. So I said, no, it was Mrs. Jones I wanted. Would you mind waiting in the waiting room? And she said, I am Mrs. Jones. She'd lost stones in weight and looked amazing. And also when we did the blood test, she'd reversed her diabetes or maybe put it into remission. And that was really one of the very first times I'd ever seen diabetes put into remission. In 25 years, I hadn't seen a single case, not one. And then I had this lady come. So obviously I was fascinated. How had she done this amazing thing? And then she was very humbling because she said, you're not going to like this, Dr. Unwin. I don't think maybe I shouldn't tell you. And I thought, how terrible. This woman has changed her life And she's too embarrassed to tell the doctor how she's done it. So I said, no, please, I'm not going to shout. Obviously you know something I don't. I've got stuff to learn. Now, this is really interesting. We're going to hear from diabetes.co.uk next, from Charlotte. So they run a low-carb forum. And this lady, at the time, this patient of mine, was one of 40,000 people on a low-carb forum, and they were teaching each other how to do it. And they were saying, don't share this with your doctor, he won't like it, but just stop taking your drugs and do this, and you'll be fine. Amazing. When I went online, I just couldn't believe this enormous thing was going on. I knew nothing about it. These amazing people were backing each other up, reassuring, giving advice, and getting very good results. I tried to join because I thought, I need some of this. And I was removed as a troll, because they refused to believe that any healthcare professional would take low carb seriously. And that's how bad it was. And it gave me a commitment to help the community in any way that I could, because I felt they were disenfranchised by this. They were not represented, and they were getting wonderful results. So that's how I came originally across diabetes.co.uk. In the disclaimers, I am a medical advisor for them, but they never give me any money ever. And I think that's important, you know that, because otherwise it doesn't look good. But they don't. It's because I have shared goals with them, and if you work, I think many of us have shared goals, and if you work with people with shared goals, you can make such a difference. And when I met them, they're young, they're energetic, and I thought, I'll back you, and you're going to hear what they've done. Right, so you've had the clever woman and the glycemic index. Moving on. So yes, diabetes, type 2 diabetes. My older patients used to call it sugar diabetes, and actually they had a very good point. It's interesting, we've stopped calling it sugar diabetes now. But it is, I think, largely for most people, it is about sugar. Stress is important, sleep, things like that. For most of my patients, to be honest, it is about what they eat. So if you have type 2 diabetes, you're going to struggle to metabolize sugar. You've got a problem with it. So there was a lot of talk about moderation with sugar. Why don't you just be moderate with the sugar? Do you know, really, it's so much like whiskey. You know, should I be moderate with whiskey? Well, I'm at the surgery. I don't know, really, should I? But sugar, I think, for many people is quite addictive. And so many of my patients really struggle with moderation and are far better, if they can, doing without it altogether. Now then, quite a lot of my patients said, well, I've already stopped having the sugar, Dr. Unwin, so there's obviously nothing I can do. And this leads us back to the glycemic index, because it is about sugar, but other things, as I say, the glycemic index gives us an idea how much glucose is produced by digestion of starchy carbs. So I found a world-renowned carb expert called Dr. Jeffrey Livesey, and he was involved 30 years ago in the very beginning of the glycemic index. And I discovered from my patients that if you're trying to communicate with patients and healthcare professionals, they never got the glycemic index. They never understood it. And one of my partners said, why don't you just go away and come back with it sorted out in a way that I can understand? So I came up with the idea of teaspoons of sugar. Now, there are errors in it, but broadly, if you look there, you will see a small bowl of basmati rice, 150 grams, affects your blood glucose to the same extent as 10 teaspoons of sugar. Now, if you're communicating with patients and you're trying to get this across, they get it really fast when you start telling them that sort of thing. Reading down. Here we are, a portion of boiled potato. That hasn't got anything on it. Again, 9.1 teaspoons of sugar. A banana. Patients were always eating bananas. Some of my fattest patients were I hate bananas, hate them. They're having loads of bananas because it's a healthy fruit. Well, it is a healthy fruit, but if you have type 2 diabetes, it brings with it a glycemic burden equivalent to about 5 teaspoons of sugar. if any of you are type 2 diabetics and have a meter, you probably know some of this is true. You can test it yourself. Just eat something and see what happens. Horribly, in the UK, GPs were told not to give meters to patients because of the expense and the expense of the sticks. That's awful, because you can learn so much. Experiment on yourself, have a go, see what happens to the glycemic index. So there we are. And yet other foods do not do much to your glycemic index. So if you're thinking about dietary choices, and we're talking to patients about dietary choices, my sort of teaspoon equivalent thing is quite useful and gets it across very quickly, because I have 10-minute appointments, so I don't have very long to go on chatting. This is a related slide. I'm trying to be very quick in the practice, and a quick way is talk about people's breakfasts. Tells you a great deal about them. And there's a pretty average British breakfast: cornflakes, milk, brown toast, without the marmalade on it, and pure apple juice. And look at that, the equivalent would be 21 teaspoons of sugar. That's a hell of a start to your day if you have type 2 diabetes. Maybe you could have something else instead. So these are the sort of infographics that we develop within the practice to communicate with patients, but also with other healthcare professionals. There were some questions earlier on about how do we communicate with doctors who think this is a terrible idea, dietitians who think it's kind of murder, and not everybody likes it. But when they see these kind of facts and they accept that it's about diabetes, I find people are very reasonable with me, and their mind is far more open. So it's one way to communicate. Also, the idea of this is about information for patients. I don't tell them what to eat, but I try and give them useful information, and then they make choices. We were talking right at the beginning of the day about which future will you choose, and information is maybe how you will decide on which future you will choose, and that includes dietary choices. I promised you two clever women. And the charm. Oh, this is obviously an average British low-carb family there, and nobody else. So it's my family, as it happens. And the charming lady in the middle there, with the knife and the pitchfork, that's my wife, my charming wife Jen, and she's down there. And she's a clever woman. She's a clever woman. And what Jen brought to the picnic really was the idea that you can give information to patients, but the framing of that information can make a big difference to choices. So that hope for patients, so important. Jen has spent decades looking into the difference that hope makes to patients. If we give them hope, they're more likely to move towards the light. If we threaten them and say, if you do not control your diabetes, we will chop this off, and they just close down. I had patients I'd told off, and they'll go away for 5 years and not come back by telling them off. But if you start talking about maybe a better life, and that you can make a difference yourself, what a difference it makes to they listen to me properly and they make changes. So Jen spent a whole lifetime on clinical psychology, but for the benefit of this afternoon, we've just done one slide, which is the whole of clinical psychology done in just one slide, and we'll see if we can do clinical psychology in maybe 3 minutes. Let's have a look. So this is about changing behavior. So we think we're going to just reduce it right down to 4 steps. We're illustrating it with one of my patients who has consented to this, and you'll see where the new approach started there, and we're looking at weight. So the first thing is, what about patients' goals and doctors' goals? Can we have shared goals? So the patient's goal may not be hemoglobin A1C, because that's a very doctory thing. But it might be to get rid of a great big belly, or it might be to breathe better, or to play with your children, or something like that. So if we can link our narrative in with what they hope for, they're more interested. So this particular patient was only 43, And what did he weigh? Yeah, so when he came, he was 118 kilos. He had, at that time, 3 kids, and his agenda was playing with his children. That was what he wanted to do. He was not interested in diabetes or the tablets or anything. He said to me, "This is ridiculous. I'm 43 and I can't play with my own children." And I said, "Great point. I'm going to help you do that. Shall we do this together?" And then we had a shared goal. So the next question is, patients don't come to us with no resources. They come to us with intelligence. They come to us with resilience. They come to us with resources. So what resources? One of his best resources, he had a brilliant wife, and she was prepared to support him. The other thing, if you just look at that graph, preceding when the approach was started, he'd lost weight before. So this is a guy who already knew some stuff about losing weight. So I asked him how he'd done it and how he felt, and when he lost weight, he felt a lot better. So I said to him, "Well, you can do it. You've done it before. We'll just do it again. You can have some more support this time." The next thing is, how about, you may have your big goal, which for him was playing with his children, running in the park, that kind of thing. What about some smaller goals leading to the big goal? That's easily done. So his first small step was giving up sugar. That's a really common first step. It isn't a small one in my mind, but he said, "Right, I'll give up sugar." That was the first small step. Then we'll weigh you again in a week and do it in that way. Then the next thing is, it's particularly important that we all reflect when we've done a good thing and think about how it feels. It does something to the wiring in your brain. How do I feel better? And just think about, why do I feel better? And you're more likely to repeat the behavior again. So reflecting when we've done good things, and doctors complimenting patients. It's so powerful when I notice that they've lost weight and I compliment them on things, and then I'm having cheerful conversations with previously unhappy people. It changes the medicine. It's so much more positive. So what we've got here are 4 steps: agreeing shared goals, looking at resources, some small steps, and then reflecting on what's worked and doing it again. And then you just go around again. It's just a cycle, and you can just go around again. Now, just the thing to touch on is, patients sometimes feel bad because they think they've done badly and let you down. So I never have any truck with that. Often Christmas, many of the patients gain quite a lot of weight at Christmas and come back all disappointed. But didn't each of us get to where we are by learning from mistakes? So it's not really a mistake, it's just an opportunity to say, well, what would you do differently next Christmas? And it framed in that way, it's an opportunity, not a telling off. So that's a slight addition, perhaps, to that. Moving on. Yeah, this is just me showing off, really. So this is, I think most of you know about the hemoglobin A1C, but I ought to just, anybody here that doesn't. This gives, it's great, because what used to happen with doctors was we'd do your blood sugar and you'd just not eat a Mars bar and less chocolate on the day of the blood sugar, and it would be magically good. But now we've gone one step. The hemoglobin A1C is like, how averagely sugary have you been in the preceding 120 days? So there's no escaping from the hemoglobin A1C. So this guy, there we are, hemoglobin A1C of 13.1, and I think that was about last August, because he was in intensive care. He was very, very ill and nearly died. His diabetes was way off the scale and he got septicemia afterwards. But look now, his hemoglobin A1C has come down from 13.1% to 5.9%. And that happened, look how rapidly that graph drops down. So that happened in about 3 months. And he came off liraglutide. In fact, he came off all his diabetes medication in that time, and he now has the best diabetic control that he's had. I've looked after him for some years, as you can see, and that's the best diabetic control he's had in years. the important thing is how proud he is, and that he's reflecting how he feels, and his wife is so proud of him, and so he's that bit safer because we're reflecting on his massive achievement. He's very much livelier too, very much livelier. I should go back to the other case. Of course he got to play with the children. I didn't tell you, did I? Yes, he definitely got to play with the children and did fine, but we don't know what his future is. He may slip back again, but hopefully he could go back and learn and think about how he did it last time. Often people say, yes, David, it's all very well and good, but it probably won't last. So this is just to say, well, at least here's a case that definitely has lasted. So again, the hemoglobin A1C, and this lady had average control of her diabetes some years ago. She went low carb in 2011 in this case. She's lost 27 kilos in weight, and you see her hemoglobin A1C remains in the normal range for years. So some patients may drift, I don't know yet, but there's one. And so far it's looking quite good. It depends, I think, on to the extent to which patients stay on the diet. A bit more showing off. You heard before that we're using this approach across a whole practice instead of using drugs. What's very interesting for the doctors in the audience, if you ask patients at the point of starting medication how they feel about lifelong medication, I have discovered that they don't want the drugs. It's a surprise. I was dishing them out for 25 years, like they are, take them and go. One way to get you out of the consulting room is to give you a prescription. I never asked a patient how they felt. How do you feel about lifelong medication, and are you up for an alternative? And since I've been asking for 4 years, not a single patient, not one patient has said, give me the drugs. Not a single one. That's amazing, isn't it? But if you do that as a whole practice, as you see here, we are the pink practice, obviously, and that is every practice in our area. We're gathered into a thing called a CCG, and those are all of the practices in the area. And you'll see that our prescribing for drugs for diabetes is it's the cheapest in the area, but very much cheaper than the average, because so many patients are coming off drugs, or we're not even starting them at the beginning. At the same time, there's a small box there which shows that the overall quality of control as measured by hemoglobin A1C for the whole practice has gone up well beyond the national average. So one thing's gone up and the drugs have come down. Also, we don't refer to secondary services. We're the least referrers to diabetic clinics because, to be honest, the patients are much better. They don't need a diabetic clinic. They're looking after themselves. I wanted to make the point, it isn't just about type 2 diabetes. Now, in the first column, you've got so in our practice, we've got a case series of 125 consented patients. These are the ones that have said you can share the data, and they've agreed to have more blood tests because it's a fag, really, going for blood tests. So there's 125 of them. And these are the average results that we've achieved over the 4 years. Again, it's an average, so the average patient is on the diet for 15 months. That's because I added somebody even last week, so it spoils the average. If you look in the first column, the hemoglobin A1C, this is for people with type 2 diabetes, comes down averagely from 8.6 to 6.5. That's in percentage. In the UK, we're mainly using millimoles per mole, and that comes down from 70, which is poor control, to 47, which is only just diabetic. So I'm very proud of those results, really. Again, at the beginning, I was told, I'll be ruining the lipid profiles. Some of my colleagues were very worried about the lipid profiles with the idea that they're on full-fat milk and they're having cheese, so on and so forth. What's very interesting, if you look at my figures, I haven't ruined the lipid profiles. So the total cholesterol has improved, the HDL has gone up, that's why it's a negative figure. The cholesterol ratio to the right of it has gone down. The triglycerides are of particular interest to me. I'm starting some new research on triglyceride levels. They can really drop very rapidly. Again, for 25 years, I never had any idea what to do with triglycerides because they don't respond well to drugs. So I just fudged it really. Said, well, I don't think they matter that much. It's the cholesterol. It's the cholesterol that matters. Triglyceride, just take the statins, you'll be fine. And that was because I didn't know what to say and I didn't know whether they were important. I didn't know, if I'm being honest. But it's wonderful now because I've got some good cases with the triglycerides. The average weight, it's been very, very steady over the years that the average patient loses about 8.6 kilos. The first 18 patients lost that. That was the first publication that Jen and I did. They lost about that. And we're still achieving that some years later. A lot of the patients come off drugs for blood pressure. The blood pressures improve. The systolic and the diastolic, you'll see there the averages. And if you bear in mind that I think a third of those patients have come off drugs, so that includes reduction, particularly in ACE inhibitors, because some of them, the blood pressure improves. They feel dizzy when they stand up, so they don't really need the medication, so I've stopped a lot of. I love it, it's called deprescribing. It makes me very happy to cross something out. It's a good day when I do some deprescribing. The final one there, the gamma GT, that's a liver function. Another really interesting thing I noticed in the early days was I could predict before patients came to see me if they were sticking with the diet or not from the liver function. The liver function seemed to respond really fast to low carb. And if you look at that, so a gamma GT is one of the enzymes that we measure for liver function. Look at the difference between the start of 87 and the finish 48. What's the p-value of that? I mean, that's a massive drop, a massive improvement in liver function. So what's wonderful about this approach, it isn't just one little thing that's wrong with your patient. It's the whole thing, and they just look healthy. They come in looking good. Do you know, I've never once been thanked for starting somebody on blood pressure medication. You know, you don't say thanks and here's a bottle, Dr. Unwin, you did really well. You started me on propranolol or something. Or here's a bunch of flowers for that metformin. Never, never. But honestly, with the low carb, so the approach has cost us money. It has. But it's given me a passion, and we've had such fun. We've had such fun. And that, other people have seen me having fun, and it's spreading, spreading, and spreading. Moving on. This is just to show, so this is a graph, and this person came to me December 2016. It was the last day of December, more or less. And it was a bad day for him because I was going to tell him that he had type 2 diabetes and his triglyceride that is really sky high. That's 4 times the upper limit of normal at 7.9. What's amazing is in only 33 days, he'd brought that triglyceride down to 1.4. He'd also significantly improved his diabetes. Look at his waist, 15 centimeters in 33 days. That's like liposuction. It's amazing. And he came in his sexy jeans because he said, these are my sexy, I haven't seen these for a long time. Amazing, such fun. Interestingly, and his cholesterol improved as well. So lots of things improved. And that didn't take very long. That was just 20 minutes chat in his case. I saw his wife as well. Very important, who's doing the cooking? Where do they live? Who's with them? And include that person. Invite them, show an interest. The wife or the partner's often interested to come, bring the whole family. Then you get to treat all of them, because I've got entire families who need help. And if you pick out one, it doesn't go so well. Now what's this? Oh, I'm getting braver and braver. When we started, I just did the pre-diabetics because I was dead scared. But now look at this, I'm doing heart failure. Wow, isn't that brave? So this was a lady on 76-year-old lady. This is actually a couple of years ago now. She was on everything for heart failure. Life was a struggle for her. And even just climbing stairs was a big problem for her. Just look at that weight loss there. So she weighs the least now. I've been measuring her weight since 1991. And she weighs significantly less now than she's ever weighed. But the important point for her is that she's able to walk around the park, and that's important to her because she's got a little dog. So that was her goal. And she had a big tummy, and she's lost that, and she's so elegant now, so elegant and proud. And her friends are all saying, how did you do it? So I'm moving on, I'm beginning to think about other things. I think particularly if you have patients with a very large abdomen, low carb can really score. I wonder what's next. Oh yes, I don't suppose Ted Naiman is here yet. Oh, we're 5. No, he's not here. Well, we've got this thing going on, so I've been trying to think about, you've been wondering about how to spread this. How do we spread this through healthcare professionals? So I've come up with an idea. We've started like this, just healthcare professionals only Google group, so you can admit what you don't know, and others will tell you and help you. Because you wouldn't like to admit in front of patients that you've no idea. But so people come on this and do. But as a bit of fun, we're doing an international who can drop the hemoglobin A1C by the biggest and who is the winner. Now, actually, at the moment, I think, although there was an amazing result this morning, wasn't there? That could be the winner. But at the moment, officially, this GP from the south of England is the winner. Ted Naiman was the winner for a while. But now, sadly, the US has lost that, and it's back to the UK. But any time of one of you wants to beat this British GP and come up with something even more impressive, well, good. But that's an amazing drop, isn't it? So I've done it for you, both in percentage and in millimoles per mole. Coming to the end. Yes, so there's lovely Jen again. So it has just changed my practice so much. I am thanked by patients now daily. Every day I am thanked because their quality of life is so much better. And when we think back to why we became doctors at the very beginning, it was to make a difference, to have some sort of a skill that meant people had better lives. I went off into the wilderness for 25 years and so nearly retired. But now I'm back in touch with this idea of making a difference is what I became a doctor for. And now I have young doctors. I have a waiting list of young doctors wanting to come and watch. And really, it's crazy because I'm not doing anything special at all. But I am back more in touch with these ideas of certainly patient goals with this low carb thing. And it's a very, very powerful mixture. So listen, I'm sure my time is up. So this is my final quote. We have eaten our way into this epidemic of obesity and diabetes. Can we eat our way out again? I think we can. Thank you so much. Thank you.